Hello, thank you for joining the ERJ Podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the European Respiratory Journal. Today I'm joined by Dr. Marcus Mall to discuss his latest paper entitled Neutrophil-derived biomarkers in bronchiectasis, identifying a common therapeutic target. Dr. Mall is a professor and chair of the Department of Pediatric Respiratory Medicine, Immunology and Intensive Care Medicine, and Cystic Fibrosis Center at the Charité University Medical Center in Berlin, Germany. Marcus, many thanks for joining us today.
Thank you for having me.
Could you tell our audience a little bit about bronchiectasis, what it is, how it is clinically diagnosed, and what symptoms patients should look for?
So it's a chronic airway disease. It is clinically characterized by chronic cough, by sputum production, by recurrent pulmonary exacerbations, meaning worsening of the symptoms, that is then associated with progressive loss of lung function and obviously impairment of quality of life. Radiologically, it's characterized by a permanent dilatation of the bronchi that reflects a structural damage of the airways, and together with the clinical symptoms, that then makes the diagnosis of bronchiectasis.
What are the common clinical symptoms that patients should look for?
So it's a chronic cough, sputum production, and then intermittent worsening of the symptoms, which we call pulmonary exacerbations, that can also be associated with really feeling bad, running a fever, and frequently then also needing admission to the hospital for IV antibiotic therapy.
Does it matter whether the cough is dry or wet?
Typically, it's a productive cough associated with sputum production. Does not mean that you cannot have a dry cough. Bronchiectasis can be caused by many etiologies, including allergic pulmonary aspergillosis, for example, which is also associated with a type 2 inflammation, which under some circumstances could also cause a dry cough, but typically it's a wet productive cough.
In the article, you argue that neutrophils play a central role in the pathogenesis of bronchiectasis. How do these immune cells cause bronchiectasis?
It is like cystic fibrosis, COPD, and neutrophilic disease. And we reviewed that in the article, that there is really significant evidence that the neutrophils play a central role in this disease. And that is mainly linked to the evidence we have so far to the secretion of a protease, neutrophil elastase, that causes proteolytic damage of the airways by degrading extracellular matrix like elastin that damages the airway wall. Now, with this damage of the airway wall, the innate host response properties, mucociliary clearance as an important host defense mechanism of the lung, does not work properly anymore. And that then really sets the stage for chronic infection with bacteria like Pseudomonas, Haemophilus, and others. That chronic infection itself is then a strong trigger for more inflammation. This more inflammation causes more lung damage, and this additional airway damage then further exacerbates the epithelial host defense defect, also by inducing mucus hypersecretion, for example. And this mechanism that occurs and perpetuates we call the vicious vortex of bronchiectasis. And the evidence we have so far by reviewing the literature on biomarkers of bronchiectasis is really that the neutrophil, by secreting the neutrophil elastase, but also other neutrophil serine proteases like cathepsin G and proteinase 3 that are co-secreted in the same granule when the neutrophils are activated, plays a key role in this process.
What is the current treatments? Let's focus on non-cystic fibrosis bronchiectasis. What should patients be on currently? And then we'll talk about the future.
So far, the treatment has really been focusing on the symptoms, or symptomatic. So obviously, airway clearance techniques to remove the mucus and thereby the inflammation on the bacterial load, so chest physiotherapy, inhalation of hypertonic saline, for example, can help to clear the mucus. Then treatment of pulmonary exacerbations, especially with antibiotics, part inhaled, but mostly systemic antibiotics, both oral as well as IV. And then also the use of macrolides, azithromycin, mostly in patients with frequent exacerbations or high symptom loads, with the idea that they do not only or probably mainly work as immunomodulatory agents in addition to antibiotic properties they have as well.
Would that be one macrolide tablet or azithromycin tablet once a day? Or is it 3 times a week? Or what is the usual or typical dosing of azithromycin?
For the immunomodulatory effects, it would be a standard long-term therapy with a 3 times per day regimen.
The U.S. Food and Drug Administration recently approved a new drug, a new therapeutic called brensocatib. How does this change the therapeutic landscape for patients living with non-cystic fibrosis bronchiectasis?
Yeah, so brensocatib is a first-in-class inhibitor of a protease called DPP1, dipeptidyl peptidase 1, which is also known as cathepsin C. And this protease is critical for activating all 3 neutrophil serine proteases in the developing neutrophils in the bone marrow. So what this drug does is it really reduces the damaging properties of these neutrophil-secreted proteases, but without interfering with any of the other host defense functions the neutrophils have, including phagocytosis or net formation or MPO formation. So this is really a first targeted therapy to reduce neutrophil-derived proteases in the airways. And in clinical trials, it has shown to significantly reduce the rate of pulmonary exacerbations. In the phase 3 trial, interestingly, at the high dose, it also slowed the decline in FEV1 and generally well tolerated and showed a good safety profile. So I think that as a first-in-class is really a breakthrough towards a more targeted therapy for bronchiectasis.
Are there any known side effects of this therapy that patients and physicians should be aware of?
It's a good question, Don. So there is a rare genetic disease that can inform us. It's called Papillon-Lefèvre, which is a loss of function of DPP1. And these patients basically have no protein function, and they can develop pretty substantial keratosis of the palms and of the feet and periodontitis. And therefore, these were adverse events of special interest that were looked for in the clinical trials. The good news here is that there were subtle changes observed, but for most people, really minor signs of hyperkeratosis or periodontal changes. But again, overall with a good tolerability and safety profile. And the explanation for this is probably that by the pharmacological inhibition, we are not reaching 100% inhibition, so we are not creating a null, if you will, but there is probably enough residual function that sort of prevents or does not lead to these severe side effects.
So far, a very encouraging safety profile of this therapeutic based on the clinical data and based on the biology. Is that correct?
Yes, that's correct. And it really supports and validates the concept that inhibition of these 3 serine neutrophil proteases is a valid therapeutic target that has benefits in patients with bronchiectasis.
So there is tremendous promise of new therapy, better and healthy lives for millions of people suffering from bronchiectasis worldwide. So this is very encouraging. Are there any last words regarding your paper or about non-cystic fibrosis bronchiectasis in general that you would like our audience to understand?
Yes. So, point I would like to make is that bronchiectasis has long been considered as an orphan disease and has received little attention in pulmonary medicine in general. And I think the epidemiology studies and now also studies on the pathophysiology over the last, and clinical studies over the last decade really showed that this is not true, and that bronchiectasis has emerged as actually the third leading chronic lung disease after COPD and asthma worldwide, with a huge unmet need. So the aim of our review was really to summarize the current knowledge on biomarkers in terms of disease severity, but also response to therapy, and also in terms of directing therapeutics development for the future at a very exciting time for bronchiectasis. And together with my co-authors, we really hope that the readers of the ERJ will find this helpful and will enjoy reading our paper.
Well, thank you. I think on that very optimistic note, bronchiectasis is now considered treatable, not only highly prevalent, but treatable. Thank you for joining us today. Dr. Mal's full paper is now available on the ERJ website.